Good morning to everybody. I will speak in Spanish, so I will ask you to use your headphones if you don't speak Spanish. Muy buenos días a todos y todas. Muy buenos días a Celeste en particular y Marc, que hoy me acompañan aquí en FLACSO. Y gracias al doctor Raúl Mercer por invitarme a dar estas palabras de apertura del Seminario Internacional sobre Salud, Reproductiva y Derechos Humanos. He tenido la oportunidad estos días de conocer al grupo de investigación que estuvo trabajando. Es un grupo internacional que incluye profesionales de distintos países y que trabajan colaborativamente. Sé que ha sido una semana muy intensa, que han estado desarrollando un marco común de investigación y que ha sido una semana muy productiva. Así que me alegro y estoy segura que ese proyecto va a dar sus frutos y que pronto vamos a estar acá viendo y compartiendo sus resultados. Quisiera agradecer especialmente a la Universidad de Lancaster del Reino Unido por el rol que ocupa en la red global LARC y por haber elegido a la Argentina y en particular a la FLACSO Argentina como un país huésped para este seminario. Como este encuentro está organizado por una red, yo quisiera destacar el tipo de trabajo que realizamos en FLACSO, porque es efectivamente un trabajo en red. Nosotros somos una red latinoamericana de facultades, ese es nuestro origen. Pero además hay otra manera de entender el trabajo en red, que es, natural en FLACSO, que es que nosotros construimos conocimiento de manera compartida. Y lo construimos con otras instituciones académicas, pero lo construimos también con la gestión pública y lo construimos también con organizaciones de la sociedad civil. Y eso es casi, les diría, una decisión metodológica de cómo se construye el conocimiento relevante para impactar en las políticas públicas. A veces a los investigadores nos acusan de que hacemos conocimiento muy teórico. Nosotros afinamos nuestras preguntas de investigación cuando compartimos la producción del conocimiento con otros actores. Y esa es la propuesta de FLACSO Argentina. Y en ese sentido, esta convocatoria y esta red para nosotros es una instancia más de algo que hacemos cotidianamente. Y por eso nos alegra y nos es tan natural trabajar de esa manera. Esas sin duda son redes de las que formamos parte, pero también existen otras redes al interior de la FLACSO Argentina. La FLACSO Argentina está organizada en 13 departamentos distintos y en ese sentido yo quiero valorar el trabajo interdisciplinario, que a veces es muy difícil de lograr porque hay una pluralidad de trayectorias, de intereses, de vínculos institucionales, de los actores que forman la FLACSO Argentina. Y entonces yo aprovecho para saludar al Programa de Salud y Desarrollo Humano que está aquí hoy presente y que cataliza esa colaboración interdisciplinaria de la FLACSO. Así que gracias Carlota, Karina, Mariela y Renzo, que también deben estar, si no están acá, conectados. De más está decir que el tema de la salud reproductiva y los derechos humanos destaca la importancia de los estudios comparados como fundamentación para actividades de incidencia política en los respectivos países, considerando los avances y retrocesos en materia de derechos humanos. Pero, si yo pudiera resumir mi mensaje de hoy para ustedes, yo diría que quisiera dar la bienvenida a todos a la FLACSO Argentina, agradecer y reconocer a las instituciones participantes, recalcar la importancia de abordar las cuestiones de salud desde la perspectiva de los derechos humanos, de los determinantes sociales, más allá de las cuestiones biomédicas, de las cuestiones asistenciales o de las perspectivas exclusivamente o eminentemente sanitaristas. Y remarcar también el compromiso que tiene FLACSO para facilitar estas y otras actividades con la gestión del conocimiento en cooperación, de manera cooperativa, y también nuestro interés en profundizar esas relaciones para tener un intercambio activo y fluido en los procesos de formación de posgrado. Así que esta instancia para mí es una instancia de reconocimiento y de celebración de este encuentro. Muchísimas gracias por estar aquí y que tengan un trabajo muy productivo durante todo el día. Le damos la palabra ahora a Marc de la Universidad, ¿no? ¿A Celeste? Ok, Celeste está virtual.
Bueno, muchísimas gracias. Muchas gracias por invitarnos. Quería agradecer, me presento, perdón, yo soy Celeste Leonardo y del Fondo de Población de Naciones Unidas en Argentina. Quería en primer lugar agradecer a las instituciones organizadoras de este evento y en particular a FLACSO Argentina que nos invitaron a sumarnos a este seminario internacional, y también, bueno, con FLACSO venimos trabajando desde hace varios años en materia de educación sexual integral. Este espacio nos resulta particularmente valioso porque reúne dos temas que son claves en materia de salud y de derechos sexuales y reproductivos: el acceso a métodos anticonceptivos de larga duración y la educación sexual integral. Y yo me quería referir o quería destacar una experiencia aquí en Argentina que venimos desarrollando desde UNFPA, junto al Plan Nacional de Prevención del Embarazo No Intencional en la Adolescencia del Ministerio de Salud de la Nación. Y allí en 2021, desde la Oficina Regional de UNFPA para Latinoamérica y el Caribe, se desarrolló una estrategia para mejorar el uso de métodos anticonceptivos de larga duración, en particular el uso de DIU con foco en la población adolescente. Y ahí se conformó un primer grupo de países para desarrollar esta experiencia, y Argentina fue elegido en esta primera instancia. Y para esa selección se tuvieron en cuenta dos cuestiones que quería resaltar y que me parecen interesantes para la charla. Por un lado, la viabilidad e implementación junto al Plan N y al Plan de Prevención del Embarazo No Intencional en la Adolescencia, y por el otro lado, los datos que tenemos en Argentina en materia del embarazo no intencional en la adolescencia. Sabemos que aquí en Argentina se estima que 7 de cada 10 embarazos en adolescentes entre 15 y 19 años fueron no intencionales, y este número se eleva a 8 de cada 10 cuando miramos o nos focalizamos en las niñas menores de 15 años, lo cual tiene una especial preocupación debido a las situaciones de abuso y de violencia sexual. Y esto también está vinculado con las tasas de fecundidad adolescente en Argentina, que si bien la tasa que tenemos a nivel nacional es una tasa inferior a la media regional, si miramos algunas provincias en particular, vemos que el indicador se eleva a 3 veces a la tasa a nivel nacional, lo cual es preocupante esas tasas en algunas provincias. Entonces, por ello nos propusimos, se seleccionó Argentina y desarrollamos este proyecto que llamamos Proyecto de Escalamiento de LARC, de métodos anticonceptivos de larga duración, y nos propusimos 3 objetivos en concreto. Por un lado, mejorar la calidad de la oferta de métodos anticonceptivos en los servicios mediante el fortalecimiento de la capacitación de los proveedores de servicios, fortalecer la capacitación en consejería para que estos métodos sean ofrecidos en el marco de la libre elección informada, potenciando la oferta de la anticoncepción, también en el periodo post-evento obstétrico, post-aborto y posparto, y fortalecer el sistema de monitoreo y evaluación. Y allí durante el 2021 se implementó una primera etapa del proyecto, se seleccionaron 2 provincias, Salta y Catamarca, y después en el 2022 se sumaron otras 2 provincias más de nuestro país, Chaco y Formosa, todas provincias del norte argentino. Y ahí, solo para destacar brevemente algunos de los resultados de esta experiencia, allí se fortalecieron los circuitos de referencia y de contrarreferencia en el proceso de gestión de insumos en estas 4 provincias que recién mencioné. Ahí alcanzamos a 6 hospitales y 30 establecimientos del primer nivel, incrementando el uso de métodos anticonceptivos de larga duración con foco en la población adolescente y en el post-evento obstétrico inmediato. Más de 8.000 mujeres y adolescentes se retiraron con un LARC en anticoncepción inmediata post-evento obstétrico, y aproximadamente el 50% de estas poblaciones eran adolescentes. Y se capacitaron a más de 280 integrantes de equipos de salud. Este año la idea es continuar en 3 provincias, además de las 4 provincias en las que ya estamos, continuar con 3 provincias más. Así que bueno, me pareció una experiencia también interesante para compartirla. Y finalmente quería destacar que en Argentina esta tasa de fecundidad que recién mencioné está decayendo, viene creciendo de manera sostenida, y este descenso es más pronunciado en las provincias en donde se está implementando el plan de prevención del embarazo no intencional en la adolescencia, el plan ENIA, y ahí desde UNFPA estamos indagando en las causas de esta reducción de la tasa de fecundidad adolescente, pero las primeras hipótesis nos indican que hay un fenómeno que es multicausal, que combina por un lado la garantía y el acceso a los métodos anticonceptivos, en particular los métodos anticonceptivos de larga duración, pero también el fortalecimiento de la educación sexual integral. Así que me parece súper interesante poder estar compartiendo estas experiencias, escucharles y, bueno, conversar sobre estos temas y focalizarnos, obviamente, en fortalecer los derechos sexuales y reproductivos de las niñas, de las adolescentes y de las mujeres. Así que, bueno, muchísimas gracias por esta invitación.
Me? Gracias. Well, first of all, I'd like to just say hello to everybody from Lancaster. Hello, coming from Lancaster. I am Mark Limmer. I'm a professor in adolescent public health, and currently I'm the head of the Division of Health Research at Lancaster University. And this is now, I think, the second collaborative piece of work we've undertaken with FLACSO, and I'm really glad to see that kind of growth in the connection between the two institutions. As a division within Lancaster University, we have a commitment to learning, I think, from international partners around how we can do things differently and better in the UK. I think for a country that is so wealthy and so privileged, we have actually very poor health outcomes. And we're facing at the moment a kind of socially conservative series of forces across the country, which are making access to sexual and reproductive health rights significantly problematic in the UK. What we don't have, and what I've been learning from Raoul and Carlotta and colleagues here, what we don't have in the UK is a commitment to rights. We don't have a rights agenda. And I think we're learning from you about how important that might be to put in place. But also I think some of the limitations of challenges about how, whether if you have rights, you also have to have access to and the ability to implement and practice those rights. And they are existing challenges. So we came into this collaboration with FLACSO and with our partners from Nepal, Uganda, Mexico, the US. I've not forgotten anyone. No, that's for that collaboration, with a sense that by bringing together our combined expertise, knowledge and experience, we may be able to find new and different solutions to problems that we share. The other thing that I think for me is really important about this collaboration is it's an opportunity to bring together FLACSO and Lancaster in a little bit of a more formal way. We've had informal relationships for some time, but we're very keen to think about how we offer studentships across the two institutions and ideally more broadly across the collaboration, how we share teaching, how we share knowledge between the two organisations more formally. So that's a conversation I'm looking forward to having later. But finally, I'd just say, I think this week we've been together all week, and you're going to hear some of the fruits of what we've been doing. But I think this week has been, for me, a really energising kind of week, bringing together people who are generous in sharing their knowledge and expertise, willing to challenge and be challenged. And I think we are in the process of creating something that is really good. So I'm very proud of that and very pleased to be here. So thank you.
Thank you so much, Mark, for your words, and Celeste. And I think that we will proceed to the seminar. So the people from the first panel, please approach to the table.
Yeah. So good morning, bon dia. My name is Rachel Eastham. I'm from Lancaster University. And when I talk today, I'm going to be speaking in English. So if you don't speak English, you can use your headphones. I'm going to be moderating the session today. So I'm going to be creating some connections between different parts of the session as we proceed. But in the first instance, I would just like to extend huge thank yous to FLACSO for hosting us here for this week. Everybody who's been involved has been absolutely fantastic. I'd like to specifically thank Raul, Carlotta, Karina, Mariella, and Pilar for all of your involvement in the sessions throughout the week. The good humour and kind of generosity of spirit has been very much appreciated, along with the opportunity to develop in so many ways, I think, our thinking on this particular topic. So I'm going to hand over first to Mark Limmer, who's going to do a bit of scene setting around the project as a whole. Mark, take it away.
Thank you. Can I have I need to see those. Oh, excuse me. Thank you. So, so I'm Mark Limmer, as I said before, from Lancaster University. So I just want my role really for this first bit is to introduce you to the work that we've already undertaken or are undertaking with this collaboration. And then we're going to hear from the different countries, and then we'll kind of talk a little bit about our future plans. But on the slide you can see before, this is our collaboration as it stands at the moment, and it's I think it's a broad collaboration. It's grown organically from people that we knew of and respected their work, from connections that we've made from our own kind of networks, and I think one of the strengths of what we have here is it's a very kind of organic and a coalition that's come together because we wanted to work together, which for those of you who work in research isn't always the case, sadly. Sorry about this. So why did we start? Well, I think we had some shared concerns, and I think we've unpicked some of these concerns a little bit more. But I think in the beginning, our concerns were really centred around the uncritical provision of long-acting reversible contraception. I can say LARC after that now, and also the potential that gives us for coercive practice. So we don't come from a position that says LARC is intrinsically problematic. LARC has a massive potential for benefit for so many people across the world. But what we are seeing in various pockets, in various places, and we'll hear about some of them today, is how the over-focus on LARC has the potential to result in levels of coercion, and also to reflect some of the more broad sort of social considerations about who we think are ideal parents, who should parent, how do we control the reproduction of people who we think we may not necessarily want to do that. So some of the things that some of the coercive practices we've kind of thought about, we've identified is the use of incentives and targets, a very big thing in the UK and I think in other countries, that actually pushes providers to encourage women to have LARCs fitted, not necessarily against their will quite, but that's a very strong direction of advice. We have experience in the UK and elsewhere of LARC as a condition for accessing social and health services. So young women being told that you can access this service, this whole load of social services and support, but one of the requirements of that access is that you have a LARC or some other contraception fitted. So conditional use of LARC, which is problematic. And also, I think we have across the coalition, I guess, we have a limited. We're going to talk about sex education later, but in the UK and other settings, we're not very good with the information that we give around LARC. So when we're trying to talk about informed choices to have LARC, actually we're not very good often at the information part, and that leaves people vulnerable to to being pressurised or persuaded into using LARC. And as I said before, I think the other thing why we're really interested in this collaboration is that we were, from a UK perspective, particularly very, very interested in trying to embrace the idea of a rights-based approach to some of this work, which we don't historically have. So the collaboration had two aims, really. First of all, was to review the evidence in the selected countries, and the selected countries were those countries within our collaboration, and we quite explicitly wanted to build capacity. This is when we came together, we realised we were probably 6 or 7 really busy people, and that's not enough to do some of the work. So we needed to build some more capacity into the collaboration. And we wanted to do that by bringing together this international collaboration that included, we very clearly wanted to include early career researchers in the collaboration and activists from across these 5, 6 now countries. So the aims, 3 aims. We wanted to review the evidence that's there, and you're going to hear a little bit more about this in the systematic review, which Vicky will talk about in a few moments. We wanted to build capacity so that we could extend and build the collaboration and do some worthwhile and useful research and activist work. And we're really keen. This is and it's becoming clear that this is an issue throughout the world. But this isn't an area of work that is particularly well funded by research councils, and we've struggled, I think, in all honesty, to bring in the kind of money that we would like to do some of the work that we would do, and that remains an ambition. We have to try and find ways to bring the larger scale funding that will allow us to do some bigger collaborative work. So very quickly just saying what we've done so far. We've drawn together and synthesised the evidence through a systematic review, and Vicky's going to talk about that later. And it reflects a particular, I think, the bias that exists within the published literature, but it's a value in the sense that it tells us what's out there and being used as a body of knowledge. We did some work around sharing the findings from each of the country case studies, so each of the case studies that were done. We held 2 seminars about 18 months ago where people were able to talk about their country case studies, the LARC has its experience in their country, and that was shared with publicly and opened up useful discussions and more and further food for thought for the rest of us. And then our third activity that we want to do is develop this research programme, and that's what we've been trying to do this week, and we'll say a little bit more about at the end of this talk. So finally, just want to say something about the country case studies, because they occupied an awful, a good proportion of our time, and they were conducted as part of our capacity building by experienced researchers working alongside early career researchers, in the hope that would start to build in each of the institutions at least some critical mass of people who are interested in these subjects and build some capacity and interest within institutions. And we're asking each country to consider 2 questions really. What are the policies and programmes surrounding human rights and LARC? So what should exist? What are the programmes that are there? If there are any indeed, what are they there? And then and also a reflection on what the main human rights concerns are in relation to LARC provision. So what is it that for each country seem to be the priority? What is it that we really need to be addressing? And we were very keen through that process to try and draw together some common themes that would allow us to develop further work and collaboration together, but also to help us understand actually what are the common threads that run through us all. And these are some of the themes, and Rachel at the moment is writing up some of this work for publication. But some of the sort of themes that are starting to emerge already is the absolute importance of how the needing to understand the political, economic, social, and I think increasingly historical context within which these LARC policies are designed. These policies and practices are coming from a history of the way we've addressed contraception, addressed parenthood, addressed reproductive health and rights. So understanding that is really important if we're going to make any meaningful intervention or change. The other thing that emerged very clearly was that young people are targeted for LARC. Young people are the target for LARC across all countries, and that's not of itself. I think we didn't feel that's of itself necessarily problematic, but it's also it is a time when actually it is a group for whom there is potential for vulnerability. that actually young people don't have the same levels of power and control over themselves and their bodies and their choices. And so if we're going to target particular interventions on young people, we have to be very careful and very clear that we're doing that in a way that isn't abusive and coercive. The other thing that came clear from it, and this in some ways shouldn't be a surprise, but the key driver for LARC was reduction in pregnancy, and that's kind of what it's for, so it's not necessarily that surprising. But our concern was that driver, the centrality of that as a driver was obscuring some of the other things that we would consider to be part of the rights of being a fully sexual person. It's not just about reducing pregnancy. So we're worried about what gets excluded and obscured from those things. So is this really... The fact that somebody's not getting pregnant doesn't mean they're not a victim of sexual violence or coercion or other things. And finally, it became very clear very quickly that rights-based approaches were not universal. But even where they were they're not always well operationalised. The operationalisation, which is our word of the week this week, the operationalisation of LARC, of the right to LARC, is actually challenging in itself. So having the right is important, and we recognise that, but it's only part of the battle. Sorry, and I've just over-clicked.
It's okay. Thank you very much, Mark. So as Mark mentioned, part of the project was a systematic review, which is now in publication. And this has been created by the work of the collaboration. And I'm going to pass over to Vicky Boydell, who is joining us remotely from the United Kingdom, who led on the authorship of this paper and is going to fill you in.
Great, thank you, Rachel. Very nice to be with you all. Apologies, I'm not there in person, and I'm going to be speaking in English. So I'm very pleased to share with you some of the findings from the systematic review on coercion in LARC's programs that we undertook as the kind of first activity of the Global LARC Rights Collaborative. This was really truly a group effort, both in terms of, designing how we were going to do the review, also in terms of, the search strategy and how that was undertaken, and the analysis as well. So hopefully this will be published in the coming months, so it will be widely available to share. So can we go to the next slide, Rachel, please? Thank you. So our approach to the systematic review. So this is a systematic review that was registered, and we took it specifically to understand the evidence out there on human rights issues surrounding long-acting reversible contraceptive method programming. And we searched over 9 different databases in law, in social science, and in public health between May and July 2021. And you can imagine looking across 9 different databases with search terms related to long-acting reversible contraceptives, as well as all the different human rights terms that we'd taken from the WHO's human rights framework around contraceptive care and information. We had over 12,000 abstracts or unique records that we pulled, which took a team of 6 people to review and kind of assess against eligibility criteria. And from that, we identified 92 relevant papers, about 13 of which came from the law discipline, around 60 came from public health, and 20 came from social sciences. So if you move to the next slide, I'm going to summarize kind of the 3 key lessons that we learned from this review. The kind of primary lesson that we drew from looking across these 92 different papers across different disciplines is that all the cases of coercion in LARC programs targeted marginalized and historically oppressed women. So these could be Indigenous women, women of African descent, low-income women, young people, drug users, women in the justice system, women receiving welfare, women with intellectual disabilities, and women in refugee camps. So all of the papers indicated that where coercion was happening in LARC programs, it was always targeted to specific populations of women, which kind of clearly demonstrates an association between coercion, LARCs, and how certain groups of people are discouraged, stigmatized, and punished for reproducing. And I think this is kind of one of the key takeaways that we had from conducting the review. The second lesson we learned is that there is a wide range of coercion, and I think Mark spoke to this earlier. And so we put together a kind of continuum of reported cases of coercion. So this is actions that take place to unduly influence people's reproductive decision-making. And this kind of it covers both those kind of direct coercive incidences, but also indirect coercion as well. So the direct and more overt coercive practices we found in the literature, for example, inserting an IUD postpartum without informing women who were, being targeted, was clearly, a direct coercion and passes any kind of threshold of legal code and conduct. And this is what we associate with commissions and, clearly, as a human rights violation. But we also found examples of less explicit forms of coercion. And this was giving biased information when counseling, missing out information or prioritizing certain information in those instances, and, are often tied to kind of wider structural conditions and systems that are attempting to constrain certain populations' choices about their bodies and about their family life more broadly. We also found across, the different disciplines we were looking at, that systemic factors that lead either to direct or indirect, coercion around reproductive decision-making using LARCs was often framed as social determinants. And in a way, it was very depoliticized, but in of itself had the same effect as a more coercive, a direct coercive engagement. And I think what was also quite telling, reading across these different cases of coercion in LARC's programming, is that these types of coercion, direct or indirect, are not mutually exclusive. They often overlapped and intersected with each other. So the final lesson, that we learned from looking at this evidence, and I think is a really, I think we anticipated this to be the case when we started conducting the review at the start, but I think we were all taken aback when we realized the extent of it, is that, there's some significant biases in the evidence that is available, and the majority of information on LARC and coercive programming is predominantly focused in the United States and Northwest Europe. And you can see, the bulk of the papers, over 70 papers of the 90 were taken from those settings, which means we have very, very little account of what's happening in kind of diverse global settings. That I think, the work that the collaborative has been doing goes a long way to start to remedy that knowledge gap. So I'll hand it back to you, Rachel, now, and thank you. And apologies, perdona, porque no puedo hablar español.
Thank you very much, Vicky. So as Vicky has indicated, we're now going to move on to hearing some of these voices from the collaborative. So our first speaker who will be joining us from Nepal is Manju Mahajan. Manju, are you able to hear us? Are you there?
Yes, I'm here. Thank you, Rachel.
Great. Are you ready to start?
Yes.
Great. Fantastic. Okay.
Yeah, thank you. Hello, everyone. This is Manju from Nepal, and I would like to thank our entire team for this invitation. And today I'll be sharing the context of LARC provision in Nepal. Sorry. So in Nepal, the socio-cultural factors such as patriarchy and social norms influences and affects women and girls' choices and decision-making capacity for SRHR. And women's empowerment has no direct role in FP decision-making among marginalized women in Nepal. So there is also a considerable level of son preferences among men in Nepal, which violates the women's SRHR. So despite the country's remarkable achievement in the health sector, the country has not been able to adequately prioritize the SRHR from a women's human rights perspective. So donor funding targets for a marginalized or disadvantaged population and motivating community-based mobilizers for generating demand for family planning services. So next slide, please. Yeah. So regarding the rights challenges with LARC provision in Nepal are barriers to gender equality, lack of accurate information, and unavailability of services, persistent discriminatory social and gender norms, unsatisfactory quality of care, weak policy, implementation, and accountability mechanism. The existing health policies are directed towards providing information on FP methods, uptake of FP methods, availability of FP methods, and reduce infertility. Women's perspectives are missing from all the policies. It is a paradigm dominated by men, which ignores the evidence that multiple forms of discrimination like patriarchy and caste system heavily impacts the women's bodily autonomy around the reproductive and sexual decision-making in Nepal. Some study shows that women who are not provided counseling and are not provided other options of postpartum family planning besides PPIOD. A discontinuation of PPIOD user even highlighted that mismatch between expectation and experiences and poor quality of counseling. 28% of Norplant users and 19% of IUCD users reported that they had to request a removal at the facility 2 or more times. So the next slide, please. So the priorities with the LARC provision in Nepal are like most of the SRHR decisions are made by males and the family members. Women's autonomy and sexual decision in Nepal is highly ignored. Clinical guidance to safeguarding women's reproductive health and human rights is needed. Therefore, a forced homogenization of women in Nepal and technical fix for women's health and rights empowerment of women through availability of LARC and contraceptives is a flawed rhetoric and must be corrected. So these issues and repercussions of related discriminations need to be highlighted while addressing sexual reproductive health and rights. So now I'm going to pass to Lawrence from Reproductive Health, Uganda. Thank you.
Thank you very much, Manju. I think I can speak from the microphone. Yeah.
Yeah. Yeah, thank you. My name is Lawrence Mhanji from Uganda. I work with Reproductive Health Uganda as monitoring and evaluation manager. And I have my colleague, Director of Programs, Dr. Ibembe. In Uganda, we have high-level poverty and unemployment coupled with a large youth population. So a big proportion of our people are in the informal sector. They are not bothered with these or accessing these LARC methods, but because of maybe because of their characteristics. The total fertility rate is high, 5 children per woman, and there is a large number of unwanted pregnancies, and it was worse during the pandemic. Restricted youth access to contraceptive sexuality education is also complicating the situation because the number of young people who are supposed to access information on contraceptives, they don't have that chance. There is limited involvement of male in family planning services, and many of our women are from very distant places. Therefore, they would want, I think, if their partners were involved or interested, probably would help them with transport or money to access these health facilities. We are experiencing a large proportion of refugees, influx from neighboring countries because of instabilities. And that one is actually stretching the health facilities services because the number of providers are not enough. And we also have, although there is improvement in the provision of SRH services, but the unmet need for family planning services is still high. And we have policies to promote SRH service provision, but some of them are not supportive, some of them are restricted. There is also growing opposition in the country to oppose SRH. Next slide. We have challenges regarding LARC provision in the country. Funding, the provision of LARC methods is largely depends on donor funding. And so the government has, there's a lot of efforts to advocate for government development, but it's not, their responsiveness is not yet enough. Our service providers have insufficient or incorrect information regarding a number of methods. There is also inadequate access to information and services. There's inadequate staffing of health providers at the facilities. And facility readiness and equipment provide FP and use-friendly services also inadequate. There is not proper planning for family planning mixed methods. Medicine to handle side effects are lacking, and there is regular supply chain disruptions. You find there are some facilities have methods, others don't have methods. And there is also lack of male involvement, I think, which we need to push forward. Regarding priorities, I think what we need is we need greater government involvement. So we need to advocate this with a joint effort. Enhance community awareness and mobilization, and improve supply chain, and also improve feedback mechanisms to monitor usage, and improve male involvement, and explore innovative ways to increase access. Thank you very much.
Thank you very much, Lawrence.
I pass it on to Mark.
Thanks, Lawrence. So I'm just going to give a very brief, I guess, kind of sense of the context for LARC provision within the UK. And I think I think I took a slightly historical look at this. We have a history of reproductive policy and practice that I think kind of has contributed and reflects a number of things that are problematic in our current attempts to provide LARC equitably in the UK. And one of the ones that I think I've alluded to before, but I think we have within the UK assumptions of what constitutes ideal, responsible, and approved parent. So we have a very strong sense that's driven by policy into thinking about who it is that should be able to be a parent, or at least, and in some cases at what time that's appropriate. That has driven so many of our kind of policies around how we deal with LARC, but with other forms of contraception across different populations. So young people with learning disabilities, people in the care system, people who are poor and have no immediate means to contribute economically. All of these are constituted as non-ideal parents. I think that, and this has for us, I think, some quite unsettling and concerning kind of echoes of some of the kind of history of eugenics, which has plagued Europe and most countries over the years. And I think we've had conversations in the UK about whether the usefulness of re-engaging with the language of eugenics, but I think it's a really important part of our history which we mustn't lose sight of. The other thing, I think, as I said before, the UK is extremely, compared to most countries in the world, extremely well-resourced country. We somehow managed to significantly and consistently under-resource sexual and reproductive health services. They're not seen as priority services, and where they are seen as priorities, they're there to deal with a particular priority. So we will put a lot of resources into reducing teenage pregnancy, but we won't necessarily think more holistically and globally. And what we're seeing over the last few years is an increase in commercialization, fragmentation, and targeting of services. We have a National Health Service, but the National Health Service is an umbrella which hides a whole range of kind of commercial and fragmented practices as we privatize various parts of sexual health, of health provision generally. And sexual health has been one where there has been a particular interest in marketizing. In the parts of the world where Rachel and I come from, Virgin, the big media and airline company, were running our contraceptive services in Lancashire for a period of time. It's a very worrying kind of development. And also we have the other thing which we're going to talk about later, but we have a lack of high quality, appropriate and universal sex education in schools and other settings. We haven't historically got that right. And the focus of the sex education we do have is very much focused on prevention. So it's preventive, stopping something happening rather than any sense of autonomy and empowerment. That's right. So I think, coming back to the key challenges, I think a lack of a rights approach to the provision of contraceptive healthcare is a real challenge for us. I think because it would allow us to drive so many things forward and a policy at individual levels. We have a very strange attitude to rights within the UK, and this is that rights come with responsibilities, and actually policy often focuses much more heavily on your responsibility than your right. So do you have a right to have a child? Sort of, but you have a responsibility only to have a child if you can afford to look after it in the way that's approved. Thanks, Rach. And we have competing rights undermining the right to bodily autonomy and equitable access to contraception and LARC. So there are different claims of rights. And finally, we have, I think, I like the word socially determined social inequalities. I think it's a very political way of understanding these things. But those kind of forces impede access to the right to contraception and LARC. And so finally, our priorities, unsurprisingly, our priorities are to address the growing commercialisation of contraception services that leads to some of the targeting practice and impedes the rights to informed conversations. For the last 20 or 30 or 40 or 50 years, we've been trying to get to universal comprehensive sex education. That still must remain one of our priorities. It's been a long battle, but we still need to keep fighting for that. I think we have to, and as I say, I think establishing the right to the contraception of your choice or none is important, and addressing the social determinants of access to rights and embracing intersectionality is a key challenge for us in the UK. Thanks, Rach.
Thank you very much.
I was clapping. Sorry, and now we're moving to the US.
Thank you. Gracias y buenos días. Thank you. My name is Celia Karp. I'm joining with a perspective here from the US. I'm joining from Johns Hopkins University in Baltimore. I'm presenting today on behalf of some colleagues from the University of California, San Francisco, Kelsey Holt and Lara Cristal Ornelas, who did a lot of the preliminary work for this. So in the U.S. context, the U.S. is a country of more than 330 million people. It's a high-income country with a high level of health disparities as well, very similar to the context of the U.K. The context of long-acting contraceptive methods in the U.S. is that they have been growing in popularity, particularly over the last decade, where they've grown in use almost 5 times as much as previous years, particularly with an emphasis on the use of IUDs. As the slide indicates, the use of long-acting reversible contraceptive methods have become widely available for no cost under the Affordable Care Act, or the ACA, which was established in 2010. And before this time, many people were required to pay completely out of pocket, or were supplemented in some by their insurance companies to receive a long-acting method. The Title X program in the United States is also our largest family planning program, and supports the healthcare for about 4 million people in the United States who receive care from Title X clinics or healthcare providers. Importantly, many people also receive family planning services through private insurance companies, which connects to this point about the important role that religion plays in the United States context, not just for abortion care, but also for access to contraception. As many companies that can say they have a religious affiliation and may opt out of offering specific contraceptive methods, including long-acting reversible methods. So LARC methods also inform religion also informs different types of training for long-acting reversible methods. And due to this inequitable training, many healthcare providers feel they have a lack of confidence and competence in their ability to provide and remove long-acting methods due to their training. In recent years, there's been a growth in privately funded state LARC programs in order to increase access to and use of LARCs in the United States. Thank you. So when it comes to rights challenges related to LARCs, the U.S. is certainly no exception to this. We have a history of racialized oppression and reproductive coercion of marginalized populations. And in the U.S., this really stems from a practice of forced sterilizations of people of color and targeted LARC programs among people of lower socioeconomic status. LARC methods have also been used as a form of negotiation or a condition of parole in terms of the judicial system, such that women are, told that they can have their sentence lowered for in terms of legal context if they select to use a long-acting method. So similar to some of the conditions that are brought about in other contexts as well. And then finally, we find that there is really constrained access for method removal, long-acting method removal in the U.S., with some provider-imposed barriers. And again, this is really coming from the structure in which providers operate, not that there's one bad apple, if you will, but that providers may require women to justify additional reasons for why they might want their method removed before the period of expiration. And this process of having limited access to removal services, despite a growth in access to adopting a method, is really limiting individuals' reproductive autonomy. And finally, to end with some priorities for LARC provision in the U.S., the first is that we really want to adopt a reproductive justice framework and approach to ensuring rights-based delivery of family planning services in the United States. And for those of you who are unfamiliar with the reproductive justice movement, it was developed in the United States in the 1990s, established by women of color, and really adopts a much broader focus on the reproductive oppression of specific groups that have been historically marginalized. We also want to shift this programmatic focus from a LARC first or LARC use toward the establishment of person-centered care that focuses on individuals' preferences and needs in terms of their reproductive health. Additionally, we need to address the affordability and accessibility of these methods continually through policy reforms, particularly for some of those religious barriers that I mentioned earlier. To ensure removal services are as available as insertion services, so people can have their methods removed at their preferred timing. And then finally, to establish accountability in reproductive health services more broadly by establishing
developing person-centered outcome measures that we can hold people accountable in the delivery of rights-based care. Thank you. And I will now pass it on to my colleague Jimena from Mexico.
Bueno, muchas gracias. Me da mucho gusto estar aquí. Pues bueno, vamos a empezar a plantear el panorama de México en cuanto al contexto de la provisión de anticonceptivos reversibles de larga duración. Tendríamos que plantear el origen de la implementación de los programas de planificación familiar y anticoncepción como una respuesta gubernamental ante las problemáticas de las mujeres mexicanas en relación con su conducta reproductiva. Cuando se publicó esta política en los años 70, había una preocupación por las altas tasas de mortalidad materna e infantil, pero también tuvo que ver con las aspiraciones democráticas nacionales de desarrollo económico y bienestar social en México como un Estado nacional. Estas políticas han sido operadas históricamente por la Secretaría de Salud Pública en tanto políticas sanitarias y vigiladas por el Consejo Nacional de Población en su calidad de política nacional. En este momento, uno de los aspectos positivos es el acceso universal a los servicios de planificación familiar y anticoncepción. Es decir, cualquier persona de 10 años o más que se encuentre en México puede solicitar información, consejería y métodos anticonceptivos en cualquier unidad de salud de manera libre y gratuita. Otro aspecto positivo es que existe una amplia gama y disponibilidad de métodos anticonceptivos, aunque su distribución suele ser irregular, geográficamente hablando, ¿no? Esto generalmente significa que en las ciudades suele haber más variedad y abasto que en las comunidades rurales. Por otro lado, las políticas públicas están basadas en derechos humanos y reproductivos de las usuarias, pero su operación también puede ser muy irregular. Esto se debe, entre otras cosas, a la capacitación que tenga el personal de salud. Por último, es importante tener en cuenta que en México tenemos una severa crisis de violencia contra las mujeres y violencia de género, y esto es parte del contexto. Next slide. En cuanto a los desafíos principales que tenemos en cuestión de derechos, son en primer lugar el predominio del enfoque basado en metas orientado a disminuir la mortalidad materna, la práctica de abortos inseguros y el embarazo adolescente no deseado o no planeado. Y esto se hace únicamente por medio de la promoción de métodos anticonceptivos y frecuentemente dejando de lado otros servicios como el aborto legal, seguro y gratuito a nivel nacional. Otros dos de los grandes desafíos son la falta de acceso a la educación integral de la sexualidad científica, pública y laica, y la inclusión de distintos tipos de poblaciones, principalmente respecto a la diversidad étnica, lingüística, funcional y sexual. Ahora, las prioridades respecto a la provisión de anticonceptivos reversibles de larga duración en México son garantizar el acceso a todas las personas, con especial énfasis en las diversidades que acabo de mencionar, la capacitación y sensibilización del personal de salud, especialmente médicos y enfermeras, que son los principales responsables de proveer estos servicios, y la incorporación de otros profesionales de la salud, por ejemplo, trabajadoras sociales, promotoras comunitarias de la salud y psicólogas. El hecho de que esta población tenga un papel más activo o esté más involucrado en la provisión de información y orientación consejería podría fomentar que las usuarias tengan una información mucho más adaptada a sus necesidades, que se les proporcione el tiempo necesario para revisar sus opciones, que se respete su decisión y, por otra parte, se libera de una importante sobrecarga de trabajo a los médicos y médicas y enfermeras. También creo que es necesaria una transversalización de la perspectiva basada en derechos humanos, interseccional y centrada en las necesidades de las usuarias. Otro punto crucial es la difusión de derechos y servicios en anticoncepción y aborto legal en medios de comunicación masiva, porque esto no se está haciendo. Y finalmente es indispensable prevenir las prácticas médicas autoritarias, como la anticoncepción forzada, la coerción y el paternalismo, especialmente durante el parto, los periodos de posparto y postaborto. Y bueno, por ahora es todo. Muchas gracias. Y ahora aterrizamos en Argentina con Carlota.
Bueno, buenos días a todas, a todos. Me toca, como dijo Jimena, presentar a la Argentina. Soy Carlota Ramírez y parte del equipo de FLACSO. Bueno, en términos del contexto, algunas de las dimensiones o algunos elementos que definen y dan forma a la implementación de políticas de salud sexual y reproductiva y particularmente el acceso a métodos anticonceptivos es que la Argentina cuenta con un amplio movimiento de derechos humanos que surge como resultado de la dictadura militar y que tiene como liderazgo a las Madres de Plaza de Mayo, que entre otras cosas van a transformar de alguna manera las representaciones y los imaginarios acerca de la maternidad y que van a ser de alguna manera también el linaje del surgimiento de un movimiento de mujeres de gran masividad y con un arraigo popular que va a tener una incidencia significativa en este periodo democrático de 40 años en el desarrollo, implementación y la sanción de una serie de leyes y normas que apuntan a mejorar los derechos o garantizar los derechos de las mujeres, incluyendo los derechos sexuales y reproductivos, y parte del movimiento de mujeres que devino un movimiento feminista transnacional y regional. Llevamos 15 años de implementación de la campaña por el derecho al aborto legal, seguro y gratuito, que tenía como eslogan, porque bueno, conquistamos la ley en el 2020, tenía como eslogan educación sexual para decidir, anticonceptivos para no abortar, aborto legal para no morir. Es decir, que ha sido el movimiento ha dado forma a un modelo de salud sexual y reproductiva muy integral que no se focaliza solamente en la prevención de embarazos no intencionales, sino que tiene una mirada bastante integral y de hecho en la Argentina hace ya unos años dejamos de usar la idea de el modelo o el concepto de planificación familiar y hablamos de servicio de salud sexual integral, entendiendo que las personas planifican vidas y no familias necesariamente, pero bueno, esto es producto de nuestro contexto muy particular, que llevó también a la implementación llevamos 20 años de políticas de salud sexual y reproductiva con la creación del Programa Nacional, que es un programa federal que se crea por una ley nacional y que es el responsable de la provisión de anticoncepción gratuita en todo el territorio nacional, marcado también con el contexto de similar en México, que tenemos también una epidemia de violencia de género. Los números son un poquito distintos, pero tenemos un femicidio cada 32 horas que dan cuenta todavía de las inequidades de género que existen. En relación a los desafíos, bueno, si bien tenemos un programa en la implementación en estos 20 años ha garantizado el acceso de manera gratuita a una amplia canasta de métodos anticonceptivos, las diferencias y las inequidades regionales al interior del país son muy, muy grandes. La cobertura va desde el 5 al 50%, depende de las regiones, las provincias, los contextos particulares, y a eso hay que ponerle también una mirada interseccional porque hay grupos específicos que también tienen menos acceso y sucede lo mismo. La cobertura es en términos generales, pero el acceso al LARC es más limitado todavía. Otro de los desafíos es el costo de los insumos anticonceptivos para las personas que no tienen cobertura privada. El sistema de salud garantiza los métodos anticonceptivos y si bien estamos trabajando en algunas iniciativas a través del Fondo de Población para compras internacionales y algunos laboratorios de producción pública, necesitamos desarrollar no tenemos los mecanismos para negociar con la industria farmacéutica que determina el costo de los insumos anticonceptivos en función de la capacidad de pago de los países. La organización del sistema de salud con un modelo biomédico que es patriarcal y jerárquico también funciona muchas veces como barreras de acceso por el tema que planteaba también Jimena en México, quién toma las decisiones, quién decide, y hay una tradición de que en el sistema de salud el experto, la autoridad epistémica la tiene el profesional y no las personas, y ese es un desafío que tenemos. También otra preocupación es los sistemas de información. Contamos con sistemas de información precarios, anticuados, muchas veces son planillas de Excel que no nos permiten realmente hacer análisis de dónde están los problemas de acceso y de violación de derechos. Y bueno, una pregunta que atraviesa a todos los países que tiene que ver con poner el énfasis en la efectividad del método y preguntarnos si es suficiente enfatizar en la efectividad del método para garantizar una perspectiva de derecho en la provisión de métodos anticonceptivos. Y en relación a las prioridades que, bueno, este seminario nos permitió también poder poner en agenda y compartir con otros países, colegas, necesitamos diseñar un modelo. Si bien tenemos un marco normativo de derechos humanos, no está operacionalizado y no tenemos modelos que realmente de atención que permitan poner el énfasis en la promoción de la autonomía y están más ponen más el énfasis en la efectividad del método y en la capacidad de la usuaria de sostener, ¿no?, el tema de la adherencia, contar con indicadores y sistemas de información que nos permitan producir información para ver y poder que informen a las políticas públicas. Muchas veces diseñamos políticas en la oscuridad porque no tenemos sistemas de información comparables incluso con otros países. Incorporar el enfoque de derechos y de género a la formación de grado y de posgrado es un desafío que tenemos. Los profesionales salen con una formación muy focalizada en lo biomédico, especialmente los profesionales de la medicina, y finalmente necesitamos incorporar a los varones a las políticas de salud sexual y reproductiva desde una perspectiva de corresponsabilidad para que no sean las mujeres las que sostienen en sus cuerpos todas las decisiones reproductivas. Muchas gracias. Implican los tiempos.
Okay. Well done, everybody, for keeping to wonderful timings. So I was going to pass back to Mark to just comment on the future directions for global LARC and rights, but we thought it would flow a little bit better if I just take that moment to explain what that is. So this is what we're kind of coming to at the end of the week where we've all been working together here at FLACSO. And so what we're thinking as our future directions as of here is to focus our attention to build projects in 4 particular areas. So the first was in relation to service delivery, and this related to the idea of generating evidence to develop some transnational principles for delivering youth-inclusive contraceptive services. As Mark mentioned before, that was something that came out as one of the themes across all of the original scoping work that was done as part of the collaboration. The second is an emphasis on a project related specifically to rights. So the development of a person-centred and intersectional framework to ensure that human rights are provided in contraceptive care and access. The third is thinking around the policy and context. We've heard from many of the speakers today about the conservatism and influences that are affecting our global opportunities in relation to sexual and reproductive healthcare services. And so in thinking about this, we are interested in developing some kind of transformative, evaluative model to start to address some of those contextual barriers and how they operate across different country contexts. And finally, there was an interest across the group in considering men and the role of men in this landscape. So to think about involving men in building co-responsibility for sexual and reproductive health in a more effective way. I think that's the end of this presentation. It's not allowing me to proceed any further. So I think this means that this is now the time. We have time for questions. Raoul is going to join me, or... There are no questions? Oh, no questions. So, well, I hope you feel like you've enjoyed the process. I certainly have been doing multiple things that I've enjoyed during this process. And thank you once again to the audience for joining in. I can see we've had a really great number of attendees, participants. So thank you very much to everyone that's joined us from wherever you are in the world. And thank you very much again to FLACSO and to everybody who's shared their voice and perspective today in this session. Thank you, everybody. Yeah, could the question be written in the chat? Great.
Ya le estamos pidiendo a Ana para que escriba la pregunta.
No? Thank you, Anna. Yeah. So, yeah, is this a question about the masculinity's involvement of men in? Who would like to speak to that?
Introduce contraception as an issue of co-responsibility.
Yeah.
She understands the cultural barriers in the countries,
Mm-hmm.
they're different. Any way for a general approach
To navigate the cultural, yeah.
Bueno, no tengo la respuesta a la experiencia exitosa, pero por ahí por donde empezar ¿hablo en español? ¿Pueden traducir? ¿Habla en inglés o en español? No, hace unos años iniciamos un proceso de cooperación con México, cooperación sur-sur, y bueno, México hace muchos años que lleva adelante un programa de vasectomía sin bisturí. Ayer discutíamos en estos días si considerarlo exitoso, pero la realidad es que muchos hombres se acercan. Estamos iniciando en la Argentina también un proceso de formación en un modelo que es el de la vasectomía sin bisturí, que es un método ambulatorio que es mucho menos costoso y menos costoso en términos de lo que significa poner el cuerpo entre una anticoncepción quirúrgica para una mujer y una para un varón. Vemos que hay un cambio generacional en los varones jóvenes. Quienes se acercan en Argentina a solicitar vasectomía son varones jóvenes, que pensamos que hay una transformación en las políticas de cuidado y en las lógicas de cuidado. También vemos a más varones involucrados en tareas de cuidado, si bien todavía siguen estando sostenidas por las mujeres, lo mismo que la anticoncepción, pero pensamos que, por lo menos de los diálogos que venimos teniendo con México, que es un punto de partida, porque sí hay una demanda de los varones que no resuelve todo el problema y no necesariamente significa que van a tomar corresponsabilidad, pero sí es una manera de que se acerquen al sistema de salud. Los varones en general se acercan al sistema de salud en el caso de que van a tener un hijo o una hija, o bueno, ahora se están acercando o estamos teniendo solicitudes en un número significativo de varones, y lo que vemos es que es la puerta de entrada al sistema de salud donde necesitamos en todo caso desarrollar políticas que los involucren más en todo lo que tiene que ver con las decisiones reproductivas y también digamos, con las políticas de cuidado. En Argentina también estamos implementando un programa de acompañamiento en el marco de la ley de los 1000 días, que es el cuidado de las mujeres embarazadas y los niños, pero tratando de incorporar una lógica de la responsabilidad social y la corresponsabilidad de los cuidados, involucrando también más activamente, convocando más activamente a los varones a sumarse a las tareas de cuidado. Y creo que, de nuevo, no diría que son políticas exitosas porque son políticas muy incipientes. Bueno, México lleva 30 años de implementar de la vasectomía, pero que, bueno, lo que también estamos queriendo medir es, en términos de la equidad de género, la proporción que hay en la relación entre mujeres que hacen anticoncepción quirúrgica y varones, y nos parece que es una puerta de entrada, pero es una idea, es una puerta de entrada. En Argentina estamos trabajando con el Fondo de Población de Naciones Unidas para implementar una estrategia de poder ofrecer esta técnica, porque vemos que hay una demanda, y quizás como algunas experiencias que estamos iniciando, creo que sería importante pensar en el rol de los varones, y esto es, bueno, algo que en términos de salud sexual y reproductiva, y específicamente de anticoncepción, estamos empezando a implementar, siguiendo un poco el modelo de México en América Latina, que creo que es el único país que tiene realmente una política importante de anticoncepción dirigida a los varones, significativa y masiva. No sé, Jimé, si quieres decir algo más.
Bueno, yo sobre esta última pregunta solo quería agregar pues también la falta de acceso y de opciones de métodos anticonceptivos reversibles para hombres, ¿no? O sea, creo que sí hay una campaña importante en México respecto a la vasectomía, pero es muy permanente, ¿no? Entonces no hay nada intermedio entre la vasectomía o los condones, ¿no? Tampoco hay muchas opciones, y creo que si no tenemos este tipo de opciones para involucrar a los hombres en el pues cuidado o la prevención de un embarazo, en este caso, que no es el único objetivo de los métodos reversibles y no es el objetivo para todas las personas probablemente, pero al final, si no tenemos opciones, pues sí, es como muy complicado involucrar a los hombres, ¿no? Entonces, es un debate que tenemos, como decía Carlota, no tenemos realmente la respuesta para esta pregunta, ¿no? Creo que necesitamos seguir investigando e innovando también en cuestión de métodos anticonceptivos. Y bueno, las investigaciones en cuestión de política pública y digo de salud pública, política pública y de las ciencias sociales, ¿no? Sí, en esta otra pregunta va a responder Celia Carp.
Hi, so I'm going to respond to the question from Monica about indicators for satisfaction with methods. So there has been a growing body of work on this area to develop person-centered outcome measures, not just to focus specifically on long-acting methods, but also for individuals who are using any type of contraceptive method or might have received counseling on family planning more broadly. In the context of the US, they're a team out of the University of California, San Francisco, led by Christine Dellendorf, who is a physician, developed a person-centered contraceptive counseling scale. It's a 4-item measure. There are 4 questions that are asked to patients who receive contraceptive counseling, regardless of whether or not they decided to use a method. But this 4-item measure can be used as a mechanism for understanding how an individual patient's needs or preferences were met during a contraceptive counseling experience. So certainly, if you're taking a focus on long-acting methods, you could compare the person-centeredness of user experiences for individuals who were using long-acting methods versus those who were using other methods, and see if the quality of care differs between those types of users. Also, in the context of Mexico, there was a scale that was recently developed that Jimena was a part of, which was the quality of contraceptive counseling scale. And this is quite a bit longer. It's 22 to 26 items, but also focuses specifically on user experiences of care. And this measure has been trimmed down to 10 items and has been validated in various contexts in sub-Saharan Africa and also in Mexico as well. So that's a measure that can be used to look at the quality of care that individuals receive, and then again to understand if there's a potential disparity for individuals who are receiving long-acting methods. Thank you. Oh, long question. I cannot see. ¿Qué dice?
Sí, acá tenemos una pregunta de Samsung SMA135M. Si podrías aclarar tu nombre, por favor. Y bueno, es una pregunta bastante larga relativamente a temas de provisión de servicios, del rol y de las competencias de las obstétricas acá en Argentina, de la ley de salud sexual. Bueno, ustedes lo pueden ver acá y le pasamos el micrófono a Carlota.
Sí, en Argentina, voy a dar un poco, la colega es argentina y voy a hablar un poco de la situación de Argentina. Se está trabajando, nosotros tenemos varios estudios, se está trabajando mucho en la importancia, el rol de las obstétricas en la universalización del acceso a servicios de salud sexual integral y particularmente el acceso a métodos anticonceptivos. La ley actual no habilita a las obstétricas en todas las licenciadas en obstetricia en todas las provincias a la colocación de métodos de larga duración. Sí, en algunas provincias, la provincia de Buenos Aires es una de ellas, requiere una certificación. Y se está trabajando en formarla, en capacitar teórica y prácticamente para que puedan tener la certificación que habilita a las obstétricas a la colocación de métodos de larga duración. Y está en debate, no sé cuál es el estatus legislativo en este momento, una nueva ley de obstétricas que incorpore en las incumbencias la colocación de métodos de larga duración. Y ahí, bueno, lo que vemos es que hay tensiones también corporativas que disputan quién tiene la capacidad o las competencias de colocar métodos de larga duración. Es una discusión que estamos teniendo en la Argentina. Pensamos que la ley va a salir próximamente y es clave el rol de las obstétricas por su formación y por la cantidad de licenciadas que tenemos en la Argentina, de poder incorporarlas, porque sí hay algunos estudios recientes que demuestran que la incorporación masiva a las políticas de salud sexual y reproductiva y a la colocación del LARC tampoco pueden prescribir misoprostol en la Argentina, y son conversaciones que estamos teniendo en este momento porque sí permitirían ampliar, no solamente ampliar el acceso en términos de que tendríamos más recursos humanos, que en este momento a veces son limitados, sino también mejorar mucho la calidad por la formación que tienen las licenciadas en obstetricia, así que es algo que se está trabajando. No tengo tan claro cómo es en el resto de los países, pero esa es la situación que tenemos en este momento en la Argentina. Hay un trabajo importante en todas las provincias de la promoción de una nueva ley que permita a las obstétricas incorporarse activamente a la provisión de métodos de larga duración.
So we are now going to, Raul, thank you for adding to the comments. We are now going to finish the session for the first part of the session anyway. So this session about long-acting reversible contraception, we will have a break for 10 minutes and then we will return in 10 minutes to hear the perspectives on comprehensive sexuality education from Karina at FLACSO. Mark Limmer will be talking about some of the types of sexualities education in the UK, and I will be talking about a specific type of community-based informal sexual pleasure and sexualities projects and workshops. So we hope you come back basically in 10 minutes. See you soon. Thank you.